Dear friends, dear organizers, thank you for this invitation. During the next 30 minutes, I will try to share my learning and also my experience with epilepsy surgery in children and adults during the last 20 years. In the beginning, I want to answer the question, what is the real goal of epilepsy surgery? And I think that our aim is to improve seizure control and, of course, secondary, to improve the life of these patients. Different epileptogenic zones need different neurosurgical techniques, and the results and patient expectations will be absolutely individual and depending of the problem. We can classify the neurosurgical techniques in three main groups: destructive, disconnective and stimulating procedures. And I will start with the most important part of epilepsy surgery, the most successful one, which is destructive surgery. The hallmark of epilepsy surgery is temporal lobectomy, which was introduced by Falconer in 1936 and which is very successful, at least in short term. Around 60 to 80% of the patients are seizure free after surgery, and the results in long term are a little bit less impressive. Let's say that 50% of the patients are seizure free in long term follow-up, which means more than 5 years. There are some specific complications like cognitive deficit and possible superior quadrantanopia. Anterior choroidal artery ischemia has to be something very rare and could provoke important sequelae. In fact, the temporal lobectomy is the only one epilepsy surgery from the resective part of epilepsy surgeries, which was randomized and controlled, and which is found to be very effective. When we compare the medical group, we found only 8% of the patients who remain seizure free and 58% of the patients who are seizure free after epilepsy surgery. This was the old randomized controlled trial from 2001, which was published by Fibe and co-authors. There is a more recent attempt to have randomized controlled trial, unfortunately with a few participants, but again the neurosurgical group was statistically more prone to have seizure freedom after surgery than the medical group. The idea of selective amygdalo hypocampectomy is to limit resection only to the most important part from the epileptogenic network in temporal lobe epilepsy, which is the amygdala and the hippocampus. And this technique was introduced in 1958 by Niemeyer. Later, Wieser and Yazergio proposed another way to go throughout the temporal stem to the amygdala and the hippocampus. There are many different ways to perform selective amygdalo hypocampectomy, but all this technique has one goal, and this is to remove this very small part of the brain, some milliliters of brain, which is in fact amygdala and hippocampus. However, the long-term results after amygdalo hypocampectomy are not so good as in cases with anterior temporal lobectomy, because amygdalo hypocampectomy is more likely to have seizure recurrence than patients with anterior temporal lobe resection. Hippocampal sclerosis is associated with good outcome, but however declined relatively frequently over the years. Legionectomy is another very famous part of epilepsy surgery. It may be the most successful and the easiest one. In fact, the first epilepsy surgery was performed by Sir Victor Horsley in 1886 when he performed successful craniotomy for focal seizures secondary to a depressed skull fracture. During the first year we have again a very good seizure control with approximately 80% of the patients who remain seizure free. After that, in long term, when we look on the follow-up, we will see some drop down of the seizure freedom, however remaining more than 60% usually. This is an example of small ganglioglioma in the temporal lobe, in the mesiotemporal lobe. And after resection we have this porencephalic cyst created by the surgeon, and the chance to achieve complete seizure control is very high, but it's not 100% because even in these cases we can observe some focal cortical dysplasia around and to have late recidive. Focal cortical dysplasia type 2B in the superior frontal gyrus, it's quite visible on when we look on the MRI. This is the superior frontal gyrus on the MRI with some even hypointensity in this gyrus with blurring of the transition between white and gray matter. And this is our intraoperative imaging with this change color of the brain. This part of the brain it's very firm and it's relatively easy to perform legionectomy in focal cortical dysplasia type 2B. Seizure and cognitive outcomes after resection of glioneuronal tumors are good in short terms, and we have only 20% of the patients who continue to have seizures. We have also good midterm results even without epileptological presurgical evaluation, and it was well described in the paper of Alexander Ristich and co-authors, where he found that even in the group of patients without epileptological presurgical evaluation, we have good outcome, and the outcome in this group reached 71%. Our team published a paper about awake epilepsy surgery in patients with focal cortical dysplasia. In this type of legionectomy, again we achieved 71% of complete seizure control after awake craniotomy and operation in language areas or in primary motor cortex area. And these results were comparable to the seizure outcome in the general anesthesia group. This means that mapping and monitoring are mandatory for epilepsy surgery, and this monitoring and mapping may provide very good results with low risk for the patient, even when the lesion is in functional zones. Dr. Gabrowski will present a special talk about this. Legionectomy in functional zones require mapping and functional MRI, intraoperative mapping, and functional MRI. It's something that is useful, but it's, in my experience, not sufficient. Here, for example, we use functional MRI, but also direct electrical stimulation in awake patient, and we succeed to perform this type of legionectomy of focal cortical dysplasia affecting the posterior part of pars triangularis of the inferior frontal gyrus just in front of the speech area, which is posterior. And we achieve complete seizure control in this case without any neurological deficits after that. The factors that are associated with seizure freedom in the surgical resection of glioneural tumors are relatively short duration of epilepsy, gross total resection of the lesion, and the absence of secondary generalized seizures. However, there are some red flags in legionectomy, and we have to know them because there are some traps to be avoided. The first one is that the epileptogenic zone may be larger or even outside the lesion. We can have dual pathology, double pathology, even other pathology like genetic or autoimmune associated epilepsy. That's why I think that even legionectomy is better to be performed in epilepsy surgery centers and not in ordinary department of neurosurgery. Zonectomy, it's maybe the most interesting part of resective surgery, because here we try to remove the epileptogenic zone, the cortical zone, which is indispensable for seizure generation and which removal is sufficient to control seizures. The idea of epileptogenic zone was developed by Talleyrand and Banco with their SEG technique introduced in 1958, and nowadays this is the most important part from the pre-surgical workup of patients with drug-resistant epilepsy. Here I present a patient with some suspicion of cortical dysplasia in the right TPO area, who was investigated with PET positron emission tomography and also with SEG electrodes in the region. Of course, we investigate not only the cortical surface but also the depth of the sulcus and especially this region where is the TPO. This is a fusion of the electrodes and the finding of the positron emission tomography. We found hypometabolism in the posterior part of the right superior temporal gyrus, and we put 2 electrodes in this region and many electrodes around to limit the resection. This is the patient after the SEG. In fact, we record seizures starting from E and O electrode, and we decide to perform legionectomy in this area, in the zone which is in fact the epileptogenic zone recorded by these electrodes. This is our resection, sparing the vessels, removing the cortex and reaching the depth of the sylvian fissure. Our resection is not very big, but successful with complete seizure control and without any neurological and neuropsychological deficit after that. Destructive thermocoagulation, it's a technique which was introduced again by Guénon and his team from Lyon. He proposed SEG guided radiofrequency thermocoagulation of epileptic fatigue, and he found that we have a lot of responders, let's say 50% responders with at least 50% seizure frequency reduction and approximately 10% of seizure freedom at the last follow-up and 1% of permanent neurological deficit as risk. Other teams have joined Guénon and his team from Lyon, for example, the team from Grenoble, and the team from Milano. Nowadays we also have series with more than 50% with stereo-EEG thermocoagulations. Here you can see Associated Professor Dimova, who performed one of our first SEEG guided thermocoagulations in the CT scan. The best indication for this surgery is periventricular nodal heterotopia, and also we can perform amygdalo hypocampectomy using this technique. We have to note, of course, the new player in the field of thermocoagulations. This is the washer interstitial thermotherapy, which was with FDA from 2007, and the first paper was published in 2008 by Carpentier. The results in these patients are good, but remains, however, less impressive, especially when we look on the long term. Here you can see that there is some drop of the seizure freedom from 78 to 50% when we compare the follow-up of 24 to 61 months. It's quite logical because radiofrequency thermocoagulations and also washer thermocoagulations frequently respect part of the epileptogenic zone, and we can observe some recidivity when we have a longer follow-up. Radiosurgery is a nice idea for distract the epileptogenic zone, but again we have to know that radiosurgery is something that could have a lot of complications like radionecrosis, and the effect of this surgery appear usually years after the procedure. My personal experience is that amygdalo hypocampectomy and temporal lobe resection are very easy and low risk neurosurgical procedures, and to shift from this procedure to ablative or a radiosurgical intervention, we have to obtain more data and maybe more follow-up, because these novel minimally invasive approaches are still comparatively less efficacious than open surgery. Disconnective surgeries is the second part of my talk, and this type of surgeries is very interesting because we can just split the epileptogenic zone and leave the brain in the cranial space, not creating a big holes. The functional hemispherectomy was introduced by Rasmussen in 1983, and after that Delalande and Villemur and Mascot proposed some modification of this technique. The first one is vertical, and the other is, let's say, horizontal or peninsular. The long-term seizure control is quite good with 70 to 80% complete seizure control, but here the complication, especially hydrocephalus, can reach 15%. The hemispherectomy is something that could be performed nowadays vertically or peninsularly. It depends from the personal surgical experience of the surgeon. I start with vertical, and after that shift to horizontal or peninsular functional hemispherectomy. The results from hemispherectomy are impressive, especially in patients with porencephalic cyst, where we have usually more than 90% seizure freedom. This is not the case for patients with focal cortical dysplasia, because we can have bilateral EEG or even bilateral MRI abnormalities when we look patient with large focal cortical dysplasia affecting one hemisphere. And this nice paper from Kosovo demonstrate that patient with cortical dysplasia has significantly lower rate of seizure freedom compared to porencephalic cyst or Rasmussen. Hemispheric surgery, it's successful, but we have to know what is the etiology of the hemispheric problem, and if there are generalized seizures, non-waterization on EEG or contralateral MRI abnormalities, because this can reduce the chance to be seizure free after surgery. Calostomy is palliative surgery, and the most important thing for calostomy is to underline that nowadays we prefer one-stage total calostomy for the treatment of pediatric generalized epilepsy and also in adult patients, and not to perform two-thirds calostomy. Everything but motor, or the procedure of Holthausen, it's an interesting disconnection which is indicated in patients with preserved motor function, where we try to spare motor function, making the connection all around the central lobe. We perform this procedure even in Armenia. It's quite interesting, and we hope that this connection has a special place in epilepsy surgery and has to be performed by all epilepsy surgery teams. Temporal lobe disconnection, it's another option. We can replace temporal parieto-occipital disconnection, can replace temporal parieto-occipital resection, because in this case we create a very, very large porencephalic cyst, and we can observe more risk from hydrocephalus or hemosiderosis, for example. Supiout transections are effective for some authors, but in my experience this technique has a very bad long-term results. The short-term results are, let's say, good, but after some period we have a recidivation of the seizures, and it's quite usual, and this is one of the reasons when systematic review in the literature is performed to find that supiout transections are controversial, and there is no evidence to support or refuse the use of supiout transection for patients with drug-resistant epilepsy. The long-term seizure outcome in patients with hypothalamic hamartoma are very good when we perform stereotactic thermocoagulation in order to disconnect the hamartoma, and this is maybe the best result achieved in this type of pathology by the team of Kameyama from Nishinigata Hospital in Japan, who achieved 88% of complete control of gelastic seizures and 78% of control for no-gelastic seizures. These results are much better than all other published results in the literature. The last and maybe the more controversial class of epilepsy surgery is epilepsy surgery with neuromodulation. The VNS was introduced in 1988 by Penry, and he reported 6 patients where you can see that 4 of them were with complete seizure control. Very impressive results, which was not supported by the other studies that follow. We know nowadays that maybe 50% of the patients have 50% of reductions of the seizures. This is a nice study by Burner team of the EEG reactivity, its predictor of individual efficacy of vagal nerve stimulation. Unfortunately, we continue to look for predictors for effect of VNS, which is a little bit strange for me, so many years after the introduction of VNS. DBS for epilepsy, again we have the first paper in 1980, very long story of DBS for epilepsy, and again the first 6 patients were quite successful in this series, but after that we achieved the same 50% responders and 60% of subjects who can be seizure free for at least 6 months. Let's say modest results. Hippocampus stimulation by Velasco family. Again, the results from Velasco family in the first 6 patients are much better than the results after introduction of the technique in another centers. Responsive neurostimulations achieve seizure control very rarely, but however in 50% we can have seizure reduction. There is also some trend to combine or even to switch from one neuromodulation to another, but in my opinion neuromodulation has to be performed only when resective surgery it's not indicated, and it has to be performed in epilepsy surgery centers, not in DBS centers, which are more prone to propose DBS. My personal impressions after 300 epilepsy surgery are that we have not to forget but not to overestimate neuromodulation in epilepsy treatment. Also, I think that pediatric epilepsy surgery is not so different than epilepsy surgery in adults. My experience with let's say 50% of pediatric patients and 50% with adult patients shows that there is no big difference in the surgical technique. Of course, there are more bilateral abnormalities, more MRI negative cases, and more frequent large resection in pediatric patients, but the technique is the same. I think that we have to have realistic expectations from epilepsy surgery and to know that the early good results could decrease over time, because we can have a recidivate of seizures even many years after surgery. And at the end, I think that maximal pre-surgical and surgical skills, for example here, temporal lobectomy, amygdalo hypocampectomy and VNS are mandatory, but also we have to perform ECG, awake surgery, everything but motor or even thermocoagulation in some patients. That's why we have to know how to perform this technique and to choose the best one, not to be focused only one technique. For example, it's only resection or only neuromodulation, because each patient is special and we have to choose our technique from our big armamentarium. Thank you for your attention.